Great, Joe, thanks for being here as well. All right, guys. So when I constructed this talk for this afternoon, I want to take us on a little bit of a journey, hence the decade in review and what's to come. And it's because we are in this time of really great transition, I would say, in global health. Those of us who are working in the field kind of feel it empirically, in that the silver bullet solutions that were available to us 30 years ago, such as vaccines, while enormously important, are not enough for the complexity of the problems for what we're seeing now. We need to really carefully consider what the next solutions are that are really going to bring direct relief of human suffering and support the human right to health. So to that end, I wanted to kind of pause with you all for this hour and examine how emergency care can really transform a neglected but really essential part of service delivery in low and middle income countries. So let me start with a personal question for you guys. Where were you, do you remember, when you decided to go into medicine or public health? What brought you to your field? Where were you when you decided that? What inspired you? I like to kind of ground this in a little bit of personal experience. For me, it was Angola in 1996, in the middle of the Civil War. And I went there expecting, I don't know, I never traveled outside the country, grand African landscapes, maybe something that would be inspiring. And what I was met with instead was civil war and child soldiers and a civilian population whose lives were really being torn apart by these landmines, right? Anti-personnel mines. And at that time, Angola was the most heavily mined place in the world. There were literally millions of mines there. And the time I spent in the hospital with these trauma surgeons, again, 19, no exposure to medicine whatsoever, really impressed on my brain, right, what landmines can do to the human body and what human suffering really means in the front lines. And so even before I knew what emergency medicine was, I had, again, zero exposure to medicine at all. I knew I wanted to figure out how I could take care of people really on the front lines of human suffering. And so emergency care here and all over the world, but really here is many things to many people. We call it the safety net of our relatively broken healthcare system, right? For some, it's like a warm bed at night for a homeless population when we have freezing temperatures. For women who are raped or trafficked, right, it's the only place they can go in the middle of the night. And really on our worst day, I can expect to show up in an emergency department and be given quality, state-of-the-art, competent care that can literally save my life. And we, again, as providers, exist on the front line of medical care to do many things, but really, again, it's to relieve suffering. But this concept of emergency care is not a reality in places where humans are suffering the most. This is John, who I met in Liberia around 2010, and his mom gave me permission to share his story with folks. And what happened to John was the simplest of emergencies. He was an 11-year-old. He climbed a coconut tree. He fell out of that tree. He had a pretty complex tib-fib fracture. And the government did not actually cover 11-year-olds for emergency medical care of any kind, and there was no emergency medical care of any kind in hospitals anyway. And so his family did not take him there. And all he needed was a reduction in a splint, right? But now that lack of the simplest of emergency care really dramatically affects his ability to walk, right? His eventual ability to work, to take care of his children. And so to understand why patients like John don't have access to emergency care and what we need to do about it, I just want to take you guys on this little review of the last decade and how we've kind of wrapped our minds around how to build some of these systems in some of the hardest to reach places. So while the U.S. has developed emergency care in the last 35 years, we know that in low and middle income countries, emergencies occur everywhere, and each day they consume lives and resources regardless of whether there are systems capable of achieving good outcomes. So Olive Kobusunier first said this in 2005 in this kind of landmark paper in the Bulletin of the WHO. And it was really this first collective call to action to the global community of like, we are missing a big part of human suffering, and what are we going to do about it? You know, to put this in context of what we understand from the historical transitions in global health, let's just pause and look back at the last 200 years, right? We've made remarkable progress. For those of us, I'm going to say the left side of the room, who've been in global health, right, for at least 10 to 15 years, we've already seen this remarkable change. We are inexorably getting better and better health outcomes. However, we are also seeing this kind of rise of complexity that's increasingly difficult to bring our minds around how do we approach in global health. And so when we look back at this, lots of historical global health folks would say, look, we had this kind of this time of pestilence, is what lots of folks call it, when with the interventions of really water and sanitation and public health made tremendous differences in kind of human health outcomes. With the advent of vaccines, we had this recession of pandemics where these infectious disease pandemics, while they are still occurring, let's be real, right? We've got a lot of things going on with measles in this current day and age, have allowed this kind of rise of non-communicable disease, and then these diseases of, depending on who you are and what you want to call it, urbanization, globalization, et cetera. We'll talk more about those in a second. But it's really pushed us to say, look, we have to change the way our minds think and conceptualize what our approach is to this. We need to think differently about, we don't have that silver bullet answer, right? We need to think constructively about how do we operationalize this? How do we finance this so we can really meet some of the most needy folks? I want to pause and highlight for you all at least 3 major global health inflection points that have profoundly influenced the way that we've approached the development of global emergency care. And the first is the HIV/AIDS epidemic. Those of you guys look way too young to remember this, right? But in the early days of the HIV epidemic, it was all about prevention, right? That was the first approach, is that we're going to be able to control this thing in low and middle income countries with prevention alone. And what we found from that, the control efforts in patient survival, especially when large dollars were put into that, say with PEPFAR or Global Fund, they changed remarkably because we decided there was no prevention without treatment. And so while primary prevention 100% is enormously important, I'm a public health person, I have an appointment at the School of Public Health, I believe in it absolutely, there is still, we cannot just do prevention without treatment, and that goes for emergency conditions as well. The second key global health inflection point I want to pull out for you is also how we addressed emergency care and obstetrics during the Millennium Development Goal era, like 2000 and 2015. And what they did was, look, when they looked at emergencies that happened around obstetrics, they put together this model that was easy to understand about why these patients were dying. And so they brought forth the model that was called the 3 delay model. It's been around for about 30 years, where they've said it's delays in seeking care, in reaching care, and receiving quality care at the facility that really kill moms who have an obstetric emergency. And they targeted interventions around those 3 delays. We've listened to those, and I'm going to show you what we've done with that in global emergency care. And then in our more recent history, this was the Lancet Commission in 2018 that looked at high-quality health systems. I don't know if any of you guys saw this. It is like health systems wonk esoterica, right? But enormously important, because what it said was this. We thought that during the MDGs, we put millions and millions of dollars into, we think it's just an access problem. Let's just get women, right, who are in labor to the hospital, and then that is actually going to improve outcomes, right? And what we found is, especially there was lots of case examples of this, but our particular one was in India where they spent tens of millions of dollars on this. That access alone did nothing to change outcomes, right? And so their conclusion is a natural one, and one that we, as many of us are clinicians in here, would say, right, which is, of course you have to marry access with quality care. But it's one that we had to learn the answer to during the MDGs. And if you guys take a closer look at this, just look at these clinical conditions. So that blue is the contribution of quality, right, to the mortality rates. And so poor quality is actually a major proportion of deaths that are happening worldwide. And for conditions that require timely action, like emergency conditions, right, poor quality is actually death sentence. If you need to be resuscitated in the next 15 minutes and that's not done well, you will die, right? So it suggests that there's this enormous impact actually that emergency care can have on the burden of current mortality. So we have to focus on access and quality of care delivered. And of course you guys are saying, yeah, of course, it makes a lot of sense. But people make this mistake in emergency care all the time. Here is a paper that was published in Lancet Global Health last year. It's a phenomenal paper. It's an enormous amount of work. They did this geocoded inventory and spatial analysis of all sub-Saharan Africa, and they looked at where people were and how far they were from hospitals, and they said 30% of people are greater than 2 hours from a hospital. Therefore, they're more than 2 hours from emergency care. And they made this fundamental flaw, right, which was equating hospital access to emergency care provision, and quality emergency care provision at that. Because I will tell you, having worked on the continent for 23 years, the vast majority of those hospitals do not have anything that looks like emergency care. So pause for a second, right? Priorities in global health, we hear about different ones all the time. And in general, the things that we recognize are the things that are vertical siloed pillars, right? These large programs that have been funded, and the first ones that we can kind of think about kind of happen in the area of infectious disease. But certainly there are some in non-communicable diseases and trauma, right? In maternal health, and even in mass casualty management. But we know that things don't work well when you just build them in horizontal pillars. In vertical pillars, right? We need things to be connected. And there have been a number of initiatives that have tried to do that. Primary health care is one that's been most successful. There's been emergency obstetric care that's tried to look at kind of what horizontal delivery looks like, as well as some global surgery things. But I'll tell you that there are big missing pieces of that, of conditions that represent the majority of morbidity and mortality. So in contrast, emergency care really has the ability to address each of these vertical pillars, as well as our hardest system level challenges like disaster, right? Because we're really trying to decrease morbidity and mortality. And emergency care, while it doesn't do primary care, let's be clear, right? But it treats the acute condition when patients are most at risk for death. So you guys will note in the midst of this, I'm not saying emergency medicine. And the reason why I'm not saying emergency medicine is when we talk about emergency medicine or EM, we consider that really the specialty. What I'm here to tell you today is I don't think that emergency medicine, the specialty, is the answer for the global burden of disease out there, right? I do think, though, that emergency care is a kind of astonishing new way of thinking about how we actually address some of these complex problems. Because when we change our mindset a little bit and stop talking about it from the medical-centric way of it's got to be a specialty, but rather what is emergency care? It's actually cross-cutting, right? It's a horizontal service delivery innovation that provides time-dependent interventions for all disease-specific emergencies. And so it's a bit of a frame shift in how you think about it. And why do people survive in places like our emergency department here? It's because we've oriented all the services and the human resources around some of these time-sensitive conditions. So it's a lot to try to figure out how to approach. 10 years ago, literally, we had almost nothing out there in the literature at all. I showed you Olive Kubasini's paper in 2005. We had to kind of start at ground zero about, first of all, how are we going to think about this? When emergency care gets operationalized through a health system, what is a good way of looking at that? So one of the kind of papers that I wrote in 2015 actually picked up that emergency obstetric 3 delay model. It applies phenomenally well to almost every emergency condition between seeking care, reaching care, and receiving quality care. You can march out what those critical time points are in the patient's experience, right? And if you want to put that in the context of health systems, here are critical time points with the delays. And we kind of put that in what our experience is with out-of-hospital care, facility-based care, and further definitive care if the patient actually needs transfer. And you can look at some of the health system factors and the patient factors. And this gets complicated pretty fast, right? This is why emergency care systems is actually a complex adaptive system. We'll talk about that in a second. It's also why there's not a silver bullet answer, right, for delivering emergency care. So let's just not look at a lot of words. Actually, let's look at what of these seeking care barriers are for emergency conditions. One is whether people even know what an emergency condition is, right? You've got to educate people before they'll seek care. We kind of take that for granted, right? And so this has been done in some of those kind of vertical interventions. But we would say, look, respiratory distress or shock looks a very similar way, no matter what the diagnosis is. We need to teach our community members kind of when to seek care. Some of their seeking care behavior is driven by what their perception is of the facility, right? You guys know this here, right? If it's a Monday evening and mom has a little kid with a, cough, fever, maybe some shortness of breath and hasn't been eating well, if it's Monday night and they've been there before and it took them 8 hours to be seen, you might not actually go there. You might wait. That certainly is the case for lots of the community folks that I've worked with in sub-Saharan Africa. Another thing that dramatically affects seeking care behaviors is also who the person is, what their resources are, right, and gender. And so I didn't actually learn this lesson until I practiced in the Middle East. Right? Women were never going to come in unaccompanied, ever, for whatever reason. It didn't matter. They could be dying. They often were dying, and they didn't come in because they needed to be accompanied by a man, right? So that is a huge barrier at time. What you think your transportation options are, right? how bad you think the roads are. You're like, it's snowing out. It's going to take me 4 hours to get there. I might not get there, even though I'm having substernal crushing chest pain. Right? Whether there's anybody to call and whether there's anybody in the community, right, who's able to help you know when there's an emergency and when to seek care. So just thinking about reaching care, some of those things are a little bit similar, but poverty tremendously influences how people reach care, right? So, for example, when I was working in Liberia, the folks who had a lot of money could immediately call somebody, get to the hospital, and right away in a taxi cab. Other people were going to have to walk, right, from their village 3-4 days with an emergent condition, with, say, worst headache of their life and focal neurologic deficit, something that would suggest stroke or something else. Being very far, obviously, is a barrier to kind of reaching care. What the season it is, right? You're not going to be able to get there if the bridge is washed out. And by the way, security, right? And folks' safety. So this is an enormous problem right now in northern DRC with Ebola treatment, right? Folks are not going to go seek treatment in an Ebola treatment unit for a clinical syndrome that meets criteria if somebody's going to shoot them on the way. It makes an enormous amount of sense, but we often don't think about it in the United States. And of course, is there anybody to call, right? So this is a little bit more Afrocentric kind of lecture, but the vast majority of places, there is no one to call. Nobody is coming, okay? Oftentimes, if there is an ambulance and it exists at that hospital, you have to know the number for the hospital and then call that number. And maybe they'll come and get you if and only if the vehicle is working. If it's not out on something else, they're not going to come emergent, and nobody's going to be able to take care of you once they pick you up. That is the reality of the vast majority of the world, truthfully, in low, middle-income countries. And then, lastly, receiving quality care, barriers at the facility. Those of us and clinicians in the room who have worked overseas know these quite well, right? We often don't have electricity. Our colleagues are working with very poor equipment. There's often nobody there, right? The human resource issue is real. And certainly want anybody trained in emergency care. We have very few on the continent who are actually trained in emergency care, be them clinical officers that are kind of like NPs, nurses, right? Medical physicians. We just don't have the human resource capacity to do so. And then the processes associated with those that we know are actually really effective at decreasing morbidity and mortality, like triage. This is why ETAT, I'm sure Joe is well familiar with, right? It was a triage tool that was created for kids who were sitting in these long queues waiting to kind of get into the outpatient department because they were dying, because they weren't being triaged, right? But oftentimes there is no triage at these facilities. People are often required to pay money for their emergent condition before they receive any treatment. And I'm not talking, we're not sure the patient has belly pain, maybe it's appendicitis, maybe it's just they, whatever, are lactose intolerant. I'm talking about like huge strokes I've seen people turned away from because they don't have money to pay, hemorrhagic shock from a road traffic accident, somebody's been hit by a car. Like folks literally are being turned away because they don't have the money. And then lastly, how good is the care that you're receiving, right? How about any standardized case management for emergency conditions? Have these ever been described, right? We've done a lot of work on that in the last couple of years. So lots to say around that kind of seeking care, reaching care, receiving quality care. We found it an effective model by way to kind of wrap our head around some of the complexity that emergency care represents. I'll tell you that the WHO stood up its very first program ever in emergency care. Can anybody guess what year? Not you. Give me anything.
2010.
All right, good guess. So 2014. They decided, now is the time. We think this might be important, right? So this is kind of astonishing, right? The WHO sees people die of emergent condition all the time, right? And by the way, most times, right, people in low and middle-income countries have an emergency condition before death, right? They're not dying quietly in their sleep. They're dying of shock, of respiratory failure, of trauma, right? Of head injury, of things like that. So it's astonishing to me that we actually had to do an enormous amount of advocacy to get the WHO to stand up the first program on emergency trauma and acute care. And the first thing they did was to define the components of the emergency care system. And so they put this in an infographic way, and this belies the enormous amount of work that I did not do, thank God, but my colleague Terry Reynolds did by getting consensus among hundreds of countries, right, about kind of what the components of emergency care actually looks like. And so while this is a really pretty graphic, what it shows you is that there's actually this I love this word, concatenation of events that have to occur together to get a patient from the scene all the way to the facility who has an emergent condition in order to receive quality care. So those of us who speak in tables, these are actually all marched out against the WHO building blocks for health systems and available online if you guys want to see it. It's a helpful way to kind of break it down if you get more into this. The other early call that we had in these early days of global emergency care and kind of building the body of knowledge and the foundation we felt like we needed to springboard off into the next steps was to measure the burden of disease. Right? This is actually a really hard thing to do because emergency care doesn't usually exist on its own, right? Emergency care needs to integrate both back to the community with primary health care, or sometimes we need further care provided in the hospital itself. But if you actually look at the global burden of disease, and this is what this paper did, and I can give you guys more details if you want to talk about it, but they categorized conditions that were amenable to emergency care. And so if you see down here on the left, they say conditions must be addressed within hours to days of onset, or conditions commonly associated with acute decompensations. So that's a pretty reasonable, right? Sir, go ahead.
The one comment I'd make, just to put it in perspective, I mean, the references to third world countries, I would argue that a lot of first world countries have emergency systems that are no better than third world countries.
100%. That is absolutely true.
Europe has this bizarre, or a lot of countries in Europe have this bizarre approach that silos emergency care, so it doesn't work like your diagram. So there should be no misconception that this is not the EU that's involved.
Yes, thank you. I mean, and for the record, let's be clear and transparent. Our emergency care system here, right? Emergency care provides, like emergency medicine here provides 46% of the care in the United States. This was the last data that we had just a couple of years ago. That is astonishing. And we're like, yeah, good for us. That's horrible, right? That should never happen in a healthcare system, right? So we are not perfect high-income countries, absolutely, and thank you for pulling that out. This is a very low middle-income country-centric talk, right? But there is, we can do better almost everywhere. So let's be clear about that.
Well, there's also very different rural, urban.
Yes.
I mean, it has to do with access, but
yes.
In this country, as well as other countries.
Yes. And that's one of the things that we talk about when the medical students come into the emergency department here, is that these issues around access and quality are no different than they are when I'm in Cape Town, or they are when I'm in Lusaka, Zambia, or Liberia, right? The reasons why people don't seek care or delay in seeking care, they're often the same, right? They're not much different. So just to call this out for you guys, because I just want you to see the power of this. The disability-adjusted life years here on the right. If you guys want to talk more about what those are later, if you're not public health people, we can chat. But those are morbidity indicators, right? And so here's the take home. If you look at the global burden of disease and you define the emergency conditions by category 1 and 2, that's 90% of deaths and 84% of dies. That's astonishing, right? When you take that and you look at the disability-adjusted life years and where the burden of disease is, not surprising, low-income countries primarily, right? But a lot in middle-income countries. And then where does this occur? Frequently in Africa, but also Southeast Asia, the Eastern Mediterranean region. We've had a number of different studies that have actually been published that confirm this. So we often take the conservative number when we go back and we talk about these things, and we say, okay, fine, maybe people don't believe that conditions are commonly associated with acute decompensations or emergency conditions. We'll just go with category 1. So often what we say is, look, 50% of the global burden of disease can be addressed by emergency care. All right, and then what is actually happening right now in low and middle income countries? So this was a status report that was published just, I think, 2 years ago, 3 years ago now. Here's what they found. We'll just break down the take-home points for you guys. There were enormous numbers of patients who were showing up in emergency units, departments. Often overseas we'll call it emergency units because nobody has the infrastructure to call it a department, right? I think 10 times greater caseload than primary care in outpatient setting. The average age of folks who are coming in are not like who's coming in for me in this emergency department here, right? They are much younger, right, and without comorbid conditions. And so the implication, if you can do an intervention that will save somebody's life or decrease their morbidity, right, like John, enormous. And then the mortality rates were so much higher than high-income countries. And so the adult mortality rate 5 to 7, pediatric mortality rates 12 to 21%. I was just in South Africa a couple weeks ago at this emergency medicine conference there, and this woman coming out of Sierra Leone in a very rural place got up and told her story about her emergency department. She's like, our mortality rates are like 18%. That's horrifying. But it's exactly in line with what we're seeing from the pediatric mortality rate. So about 15% of deaths are occurring in emergency departments. Compare that with, I'll just take a US-centric look, right? 0.04% mortality in our emergency departments here. And I'm not saying that we're so great, but rather that there are an enormous number of people dying needlessly in LMICs. Most providers have no specialty training. For you guys who have not been in the field, again, many governments, especially in Africa, do not include emergency care teaching in any of their medical education priorities. And then, by the way, the facilities, right, with fewer resources or higher mortality rates are unlikely to publish. So this is probably the most optimistic view of actually what's happening, because this was a literature review. This was pretty astonishing, right? We thought this was happening, but seeing it in black and white like that really makes you say, we've got to do something about this now. One of the things that we came to pretty early on in describing this is it's hard to describe emergency care to people, right? If you're a clinical provider, like you live it, you breathe it, but how do you actually elevate or pitch what you do on a daily basis, right? And so, and this that goes especially to when we were considering, gosh, how do we define capacities of facilities? How do we talk about this with folks who are making policy at national level? We had to figure out how to describe this. So in that same paper I showed you with the 3 delays, we actually proposed this model where, like, when we come right down to it, what does emergency care do? One of my mildly inappropriate colleagues said, we're barrier protection for death, okay? We're like the condom for death. It's not, we're not doing wellness, right? Like, I'm not telling people to go to acupuncture for their migraines, right? Like, we're dealing with road trauma accidents, right? And we're dealing with acute stroke, and we're dealing with DKA, and we're dealing with sepsis, right? Pediatric dehydration. We defined what the sentinel emergency conditions were and realized we didn't focus on diagnoses because that's not how our patients present. We said, what are, at the end of the day, the things that we must know how to do from an emergency care standpoint? What are some of the proximal determinants for that and the distal determinants for that? And when you kind of take that in whole, you're like, okay, let's get moving on what this actually means. And so one of the things that we did, especially with the African Federation for Emergency Medicine, is we took about 200 African care providers, and we sat down and we said, look, we all came to agreement about what the sentinel conditions were, and then we asked this question, what are the core capacities you think that need to be performed for that sentinel condition? And we called them signal functions. This is, again, very reminiscent of kind of actually how emergency care, emergency obstetric care approached things in the early days. And we defined those. Here are some examples. And what that does is we define what those signal functions are, is all of a sudden you're able to go into a health facility and not just count the number of gauze pads or whether they have like endotracheal tubes, but you go in there and you can ask questions about, can you perform this signal function, this capacity, right? And if not, what are the barriers to delivery of that? And so we've done some of that work in Zambia specifically. This emergency care assessment tool that came out of this work on sentinel conditions and signal functions has actually been taken up by the WHO and is a prominent portion of their health facility assessment tool. So we know that when you take those capacities, right, those signal functions, the things you're supposed to do for respiratory failure, and you actually apply them with the right processes, we have found that you can dramatically drive improved outcomes. So I'm going to give you just 2 examples here. That are in the literature. One is in Sierra Leone. They established a triage unit, and they combined the emergency and ICU. Clinical staff were trained in emergency care and triage with experienced nurse and medical officers, and they were required to be present. This often happens in low and middle income countries. Nobody's there when you show up, right, with your hemorrhagic shock. Equipment and record keeping were also enhanced a bit, and their inpatient mortality dropped in half. I cannot tell you in this hospital, if we were able to drop mortality in half, right, that would be astonishing. Queen Elizabeth Hospital in Malawi, there was a pediatric clinic. They streamlined operations. They trained in emergency care. Not a lot, okay? I'm not talking about 5 years of training in emergency care. Just on the basic of emergency care, they trained in triage and cooperation between the services, and mortality within 24 hours went from 36% to 13%. Right? These are not million-dollar projects. These are probably not even $20,000 projects, right? These are things where you're just reorienting the current resources in a way that's rational, that makes sense, and in line with what we know works in these places. I would also say, though, that one of the other things that we had to kind of get after that I was grateful to contribute to in a very small way was you cannot take PALS or ATLS or ACLS and export that to Monrovia, Liberia. It does not work, okay? And it doesn't work because, at least for let's just take ACLS, that essentially is for people who are already dead, okay? Even if you get them back, right? Number one, you often don't have the medication, you don't have the equipment, you don't have the critical care capacity to maintain that person being alive afterwards. What we needed to make something that was going to be much more rational for the setting, which was let's identify the life threats first, which by the way look a lot like sentinel conditions, difficulty in breathing, shock, altered metastatic trauma. Determine an approach to that and see what happens with that, right? As opposed to let's give all these meds and put everybody on the monitor and kind of like do this intubation stuff, right? Which I know is not all ACLS, but I'm making the point that we needed to completely change the way people, because people for decades, right, have gone into these low-income countries and taught ACLS or taught ATLS or taught PALS, and it might not be appropriate to context, and it often wasn't. And so when we needed also to kind of create an integrated triage tool as well, because for, 20 years, that pediatric triage tool, ETAP, was the only thing that we had, right? So we needed something that was combined, right? That was integrated, that included adults, that included pediatrics, that included times of regular kind of everyday emergency care, included times of surge, when they say there were mass casualties. And this had to be taught to frontline providers. So I'm gonna come back to this in a little bit. All right, we're almost through kind of some of the lit review that I think has been fairly crucial the last decade, but by the way the world thinks about emergency care, you heard the WHO just was like, oh wait, 2014, maybe this is a good idea, right? The way people talk about emergency care is completely absent when you go start looking for it. It's gotten better, but in, I think it was 2014, these mildly famous people, Paul Farmer, Jim Kin, wrote this paper in Lancet that went into deep detail about kind of what value was and how we delivered care. And the way they defined it was just this side. Here's how people enter the healthcare system. They go through longitudinal care, they do these things, right? And they come out the other side healed and well, okay? Any of us who've done emergency care in this room know that is not the way people seek care, right? Sometimes they do in best case scenario, but especially if you're marginalized, especially if you're vulnerable and poor, the times you access care is symptom-driven care, and it often has to be quite bad, right? And so we proposed a completely new model that said, look, half of the US population gets their care on the left side of this diagram. Like, we can't ignore that. And it also happens everywhere in the world, right? And so we needed to propose a very different model, a way of thinking about kind of how do we do service delivery in these contexts. So you guys have heard me say this already. Much of the policymaking and global health funders have had this enormous blind spot when it comes to emergency care and its ability to really affect morbidity and mortality. And that's despite the fact that 1 in 2 deaths, right, in LMICs are due to causes treatable by emergency conditions. Us here with our Global Emergency Care Initiative, WHO program for trauma acute care, many others kind of like in academia, have been making strides to try to pull that blindfold off of it. And we're getting there. And a lot of that has been the work of Dr. Terry Reynolds at the WHO, who I get to hang out with sometimes, which is great. And how that's culminated, actually, has been we've crossed this kind of new horizon this past year in 2019. So in May, the World Health Assembly passed the very first resolution that recognized that emergency care was a fundamental component of universal health coverage. And the reason why that is so fundamentally important, right, is because the entire agenda, basically, of the Sustainable Development Goals for health kind of get moderately distilled into universal health coverage. And so the fact that this was acknowledged and unpacked in this larger document that was passed by all the member states has enormous import. What that means, whether people are going to step up and fund this stuff, who knows? But we really felt like we crossed this big threshold in May with this resolution that was passed. So I wanted to explore briefly with you guys how I think that emergency care can address what is to come in our future global health challenges. Our evolution here in the emergency medicine in the United States really grew out of sheer necessity. But now we're at this point of reimagining how care can be transformative in health systems that are currently undergoing a huge amount of change. And I would offer this, that integrated emergency care delivery is a powerful answer to some of our most pressing global health challenges. And it's precisely because of that horizontal delivery platform that I feel like it could do that many ways. And the 3 ways I want to highlight for you guys today is in crisis, in complexity, and its ability to create value. So we talked a little bit about UHC and all these things. When the WHO comes together and says, look, here's what our strategic priorities are, this is what it says it wants to do through 2030. When you take all the different things that are rolling around there and kind of what their strategies and priorities are, they say, look, it's the triple brilliant. They want healthier populations with 1 billion more with better health and well-being, so do we, right? 1 billion more people benefiting from universal health coverage, there it is. And 1 billion more people protected from health emergencies. So here's where I think crisis, complexity, and value fit. And we're going to, each of these I could give you a whole lecture on, but we're going to just touch on each of these just to, as points of exploration together on what's to come and what we expect. The first is crisis. I began my early career in humanitarian crisis. I still sit on the WHO search team and do a bunch of stuff with that whole field. And I can tell you, after being in many humanitarian crises, I see no greater crisis today than climate change, right? Bar none. What is happening right now with climate change and its effects on human health are astonishing, and we're just not even seeing the first bits of this, right? And so I'm not going to bore you. I figured this was a great slide to kind of summarize the whole thing, in that when you have those rising sea levels, increasing CO2, rising temperatures, and more extreme weather, you get these large increases in exposure, kind of all this middle ring, to humans. And here's what happens to them when that occurs, right? We see injuries and fatalities and mental health impacts. We see forced migration. I'm already seeing that in Southern Africa right now with the drought in Zambia that's happening right now. Malnutrition, diarrheal disease, all these things have an enormous amount of science behind them. By the way, where are these people going to show up? Right, often in emergency units. Disasters as well are on the rise. We have felt that kind of in the news over the last couple years. Here's some of the paired data on it. The climate-related hydrometeorologic disasters are here, and the economic damage, and this is only through 2012, is this red line. There's been a 46% increase in extreme weather since 2000. Ultimately, climate change acts as a threat multiplier. Jay Limmer is our expert at this at the Department of Emergency Medicine. He's taught me this. It's a threat multiplier. But at the end of the day, you can distill climate change and health down to disaster and vulnerability. And who does that better than emergency medicine people, right? And emergency care systems. And I would tell you guys this. Anybody know what this is? It's a little bit provocative image here. This is ground zero in New York. What I've become convinced of in the last couple of years of talking to my colleagues and seeing what's happening in emergency units in Africa, emergency units in low and middle income countries are going to be ground zero for climate change and health effects. The people who are most vulnerable, most marginalized, who are going to feel the effects of climate change the most, do not have routine access often to healthcare systems. They are going to come into emergency units. And I will tell you, across the board, we are absolutely not ready in these countries. I've just spent 40 minutes talking to you guys about how we're not ready, right? We're getting a little bit better about understanding what that is, but we are not ready from a health system standpoint in many of these countries. Okay, so that's the crisis part. It's a little bit dark. All right, moving on to complexity. I would say that emergency care systems, right, they're complex adaptive systems, right? It's not just you get 1 + 1 = 2. In their best, most well-constructed way, they should be able to adapt and surge and reform according to need. And we desperately need something that addresses complexity because these are the predictions for what populations are going to look like on the left. And here's just NCDs, this gray, 2002 to 2030. These are some of the predictions of what these looks like, both in the world, high-income countries, low-income countries. Lots call this the triple burden of disease across the life cycle, right? And if you think health systems are going to stand up a vertical intervention for each of these things, right, that's just untenable. Nobody has the money to do that. So figuring out some of these integrated horizontal service delivery platforms like emergency care for acute conditions, I think can be enormously helpful. That also means we cannot do our interventions in just some like simple one-off silver bullet kind of way. Just implementing triage is not going to do it, right? So if you're going into a health facility or a region, you're trying to transform what the emergency care looks like, you have to do rational things. It has to be triage plus, right? Some basic emergency care education. Some of the things that we know work, like a trauma care checklist and some standardized case management tools to be able to tell people how to do this well. And I will tell you that most of the solutions, the best solutions, you guys know this from working in the field, they are locally driven, right? This is, it's not great, this is the red bed in Uganda. I'll just tell you this story, right? We think that emergency departments have to look like what I have here. It's like, our facility here is like 100 beds. It's like ridiculously amazing with all these resuscitation rooms and all this stuff. They didn't have any of that in Uganda, but they said, look, we want to change how our processes are. We're literally going to put a red sheet on the bed, and that is going to be our resuscitation bed. And we are going to do some very basic things, like you use the red patient, they go to the red bed. They get some basic emergency care. We make sure we've done the right things with our checklist. Okay? I'll tell you what the outcomes were from that in just a minute. Lastly, value. And we're almost at the end here, guys. Hang in there with me. This is a little bit more esoterica. Here's that Farmer and Kim paper I described. Value is the holy grail of service delivery. By that I mean how we deliver medical care, right? We want it to have high value. We don't want to waste money. And these guys proposed this kind of like 4 different value-based framework for global health delivery. And there's all these arrows and they go different ways, but the short and long is emergency care can address each of these things really well. Let's just look at shared delivery infrastructure, right? Resuscitating hemorrhagic shock from trauma is pretty darn similar to the things you need to do it for postpartum hemorrhage, which is pretty darn similar to things you need to do it for upper GI bleed. You need a certain couple other things in there, right? But the core of kind of the knowledge base, the medications, right, the technology of what you need can all exist in the same place and can be delivered that way. That's not how care is delivered now, often in LMICs, right? Either nobody's there or you got to know you're pregnant to go to the obstetric hospital to make sure your postpartum hemorrhage is cared for, because nobody's going to know how to deal with that at the hospital for adults and definitely not for the hospital for kids, right? And so this is why we created emergency medicine in the first place in the United States. But that shared delivery infrastructure is really critically important and something that emergency medicine absolutely can speak to. I mean, the irony, right, is that when you have care that saves somebody's life or dramatically changes their outcome, right, the value of emergency care can really be almost infinite. So I think it has enormous value to add, especially in the context of universal health coverage. So, enough esoterica. Let me ask you guys a question. We're almost there. Anybody know the efficacy for the vaccine, the influenza vaccine last season? Who knows what it'll be this year? I shouldn't say efficacy. I should say effectiveness. I'll be proper in my language.
30-40%.
Yeah. Close. Yeah. 47% effectiveness. 47% happens to be the mortality reduction that we saw in Uganda from implementation of triage and the basic emergency care course, which is 5 days. That's an astonishing freaking number. Like, that's a 50% mortality reduction from a very small intervention. Now, let's be clear. There's no magic in just teaching basic emergency care. You need people to use it, right? And so what we found in Uganda is that we had champions who were empowered to actually make changes like the resus bed, like the red bed I showed you. But they were small ones. They were not multi-million-dollar changes. They were small ones, right? There was reorientation of current resources in a rational way that was consistent with best practice. This is Terry Reynolds tweeting about just the trauma outcomes. Again, this was all told. They had 5 sentinel conditions, and we can talk more about it if you guys want afterwards. But trauma itself dropped 50%. Actually, pediatric pneumonia had a 72% reduction in mortality.
What did dedicated nurses meant? That just meant that you had nurses that worked in the ED?
So they had rotating nurses in the emergency department, but the places that were most successful had a single champion, and that was their job. Was going to be to champion triage, to champion the basic emergency care course, and make sure that everybody who came through the emergency department, because rotating providers is quite common, and it's almost universally common. There's like nobody like here who all I do is work in that emergency department. All my nurses do is work in that emergency department. They often rotate all over the hospital and sometimes, to different locations. So, 6 years ago, WHO thought emergency care only meant responding to Ebola outbreaks and earthquakes, right? To big E emergencies, as I call them. But now we have a Director General talking about how emergency care is the first point of contact with the health system for many and the delivery of definitive care for many others. We have our World Health Assembly adoption resolution. We are really on this new horizon of what this is going to look like. So, for you guys, I started this talk with my story about how I came to emergency medicine. And whatever your origin story, whether it's medicine or public health, right, we have this incredible responsibility to serve our patients at the front line of human suffering. And whether that's here in the United States or whether that's far away as Palestine or Rwanda, I would submit to you guys, no matter what your role, we're all advocates, right? The history of emergency care on the global scale is being made right now. And I would submit to you guys, we all really need to reach together to envision emergency care as a fundamental human right and to build emergency care systems worldwide. So with that, I'll pause and stop and take your questions. Thank you, guys.
Emilie, I'm just wondering from your work, one of the key drivers you had were these champions that came in and made process changes. How is that supported in a limited resource setting, given that often these providers are stretched thin and getting the administrative kind of input that values that?
Yeah, it's an enormous uphill battle, is essentially the answer. You really have to do a ton of work, and actually maybe I'll even have Andy speak to this, do a ton of work with community mobilization, with education, kind of in the facilities themselves around this. Like, no nurse is going to be tasked to be the champion and be able to create these changes without the administration fully being on board. And that has to come both bottom up and top down. Because I worked on a project in Palestine last year that had an enormous amount of World Bank funding, right? And there was a whole bunch of top-down stuff that came. Nothing changed, right? Because nobody was actually empowered to make the changes or encouraged to do so at the health facility level. And so they actually got a ton of contact with kind of like technical experts like myself who were showing up to be like, how are you guys doing? How can we help you? But they're the ones working and living it in real time, and nobody's going to make a change, right? Because that takes activation energy. These guys are overstretched already. So to answer your questions, like, there are times and places, sometimes with small grant monies, that we can actually resource them a bit to be able to do that. But essentially, that's why I think the WHO resolution, it will take years to trickle down. But that kind of frame shift of this is an essential part of how universal health coverage comes out, and that trickle down and kind of into health facilities and national structures is going to be really important as well. I mean, Andy's been doing a ton of work in Guatemala, just doing for the bottom-up side of things, the community mobilization and talking with communities about kind of what their seeking care and reaching care needs are. I've been learning a lot from it.
I mean, just a comment. I mean, if you look at Guatemala, Honduras, I mean, the immigration problem is a climate change issue.
That's exactly right. Yes.
But I'd be interested in your comments. I mean, as you compare third world versus something like Europe, they may have different definitions of emergency medicine. But I am incredibly, continually impressed with how naive many European countries are regarding what emergency medicine is. I mean, the word emergency medicine is fairly new to Europe.
Yep.
The specialty, and we may be 20 to 30 years old. In this country, they're 10 years old.
Right.
And they're just now developing professional organizations. Third world countries are, in some respects, more amenable to creating this specialty because they have less invested in it. I mean, I spent a lot of time in Italy, and emergency rooms in Italy are orthopedists, internists, and pediatricians working in silos.
Yep.
And what we tried to do with Tuscan money, and thank God it was Florence, and we spent 5 years training these docs to work together.
Yep.
But it took 5 years.
Right.
In a fairly sophisticated medical community.
Yeah, I mean, to be a little bit tongue-in-cheek about it, people are always like, why do you work so far away when you could be doing things here and doing, changing? I'm like, because it's easier. Very honestly, in some ways. Because when we go into, we're partnered with Zambia, and the Center for Global Health helped us with that memorandum of understanding to help build their emergency care capacity. They have one provider, right, for 17 million people, one emergency care provider. And so they're very interested in, how do we build frontline capacity? And so you're almost starting sometimes with almost a blank slate.
I mean, just as a local thing, how long did it take for the Department of Emergency Medicine to become a Department of Emergency Medicine?
Even here.
Yeah, in Denver.
Right, that's right.
Mass General had an internist as head of the emergency medicine. They still have an internist as head of the emergency medicine.
Yeah. Let me give you a contrasting example, though. Well, I mean, it speaks to your point. We, when I was at University of Maryland, we participated in a consortium with a lot of Abbott funding. Let's be clear, it was very well funded from Abbott, which is why it worked. And they had a strategy for transition after they stood up this emergency training program. The government was on board. The stakeholders were aligned. Within 4 years, those folks had graduated. Within 5 to 6 years, they had created a society. They were running new residency programs. They were leading the country in emergency care. I mean, that's how fast it can happen. So in less than a decade, these guys have transformed what Tanzania emergency medicine looks like. It's not that they don't have challenges, they do, but it happened dramatically faster than anything that happened here, right? It's because there weren't those layers of bureaucracy. All of a sudden, the stakeholders were aligned. It happened on a national level. By the way, there's a national health system, right, by which things can roll out. And so it's been highly successful there.
Well, and having outsiders helps. In this country, we won't have outsiders help because we know everything.
That's very true. Thank you guys very much. I won't take up any more of your time. Thanks for being here, and I'm happy to answer any other questions after.